over time, the chances of losing vision or visual field changes is very, very low. First of all, what is primary angle closure? Primary angle closure means that there is an apposition between the angle and the peripheral eyes. It could be apposition at first, just approximation, and then with time, if it continues to be very close, if these tissues are close to each other, they will start to adhere with synechiae that we call peripheral anterior synechiae, and in this case, it's going to turn into synechial angle closure. Besides angle closure, the main mechanism is pupillary block. What is pupillary block? The pupillary block glaucoma is, or pupillary block is in charge of 75% of the cases of angle closure. And the reason is, these patients are usually born with a relatively small eye, and they have a thick lens. And as we know, our lens fibers continue to grow and deposit more and more layers as we grow older. This, at some point in the patient's lifetime, usually 40s, 50s, or later, not earlier than 40 years, the thickness of the lens increases to the extent that the aqueous that's coming out through the posterior chamber starts to suffer in coming out through this very tiny approximation between the pupil and the lens. So the pupil is basically lying on the lens in this area. With the increase in the lens fold as we age, in a small eye, the iris starts to rise because the pressure gradient, which is normally between the posterior chamber and the anterior chamber around a quarter millimeter mercury, starts to rise gradually up to 10 to 15 millimeter mercury. So where would the aqueous go? It would push the iris, and this results in the gradual narrowing of the angle. If we spot the patient in this age, in this stage, follow them up or do a PI like we'll discuss, you can reverse the whole process from the front. If you don't, two things will start happening. Actually, three things. The angle will continue to narrow and the pressure will start to rise. Synechiae will build up, so that's synechial angle closure. And the third thing, and this is very important in the management decisions, please concentrate on that. With the friction, the constant friction, the trabecular mesh itself becomes damaged, it becomes dysfunctional. So even when we treat these cases and widen the angle later on, whether like we say with phaco or with even if the iris stays away from the angle after treatment, the trabecular remains dysfunctional if the angle closure was retained for a long time. And in this case, it turned the patient like an open-angle glaucoma patient. There are other, of course, mechanisms for the angle closure. There's the position and thickness of the iris, of the ciliary body, what we know as plateau. In some patients, genetically, the ciliary body is rotated forward. So in itself, it pushes or approximates the peripheral iris from the angle. And this is a different mechanism of developing glaucoma with or without pupillary block, and they have a different treatment outline. But we will discuss mostly today the pupillary block element, which is more than 75% of the cases. Other factors that they've been investigating, like the iris volume, some patients get a thicker iris than usual, or an iris that imbibes fluid from the aqueous and thickens, and so it narrows the angle. And eventually, of course, the lens. The lens is the main culprit of the angle closure. If the patient didn't have a lens, if they were atypic or pseudo, there's no way they're developing primary angle closure or glaucoma secondary to that. So the classification, I'm not sure if you're aware of it, I'll go through it very quickly. There are three types or three grades. It starts with just apposition and angle closure. Before the synechiae start to build up, before the pressure starts to rise, it's called primary angle closure suspect. So this is the patient. So the video we saw, the first video we saw in the presentation, the one with the shallow anterior chamber, you do gonioscopy, you find that the angle is closed in at least 180 degrees of the angle. So at least two quadrants are closed when the patient is looking straight ahead and without pressing with a lens that indents. Okay, there are no peripheral anterior synechiae yet, and there is no, the pressure is still normal. So this is called primary angle closure suspect. Why do we focus on compression and primary gaze in gonioscopy? Because this is a treatment in gonioscopy, something that you need to know, that when you press with the lens that indents, the angle can open up. So this is an angle closure feature, but I can see here the sclera curve, so that's like a 30. grade 30 angle. If you press, or if the patient looks towards the lens you're looking at. So you're compressing without noticing, and the angle will open, so you're overestimating the angle. So it's very important to judge the angle in primary position without compressing and in evaluation. So not to overestimate that. With time, like we said, the pressure will start probably to rise over years. We don't know how many, there are lots of studies. And or peripheral anterior synechiae will start to form, so something has gone wrong there, and the patient starts being classified as primary angle closure. They're not a suspect anymore, it's a primary angle closure disease. And then finally, with a long enough high IOP, long years of high IOP or fluctuations, glaucomatous optic neuropathy may start to develop, and the patient becomes a primary angle closure glaucoma patient. The last part of the classification is acute angle closure crisis. We stopped calling it like we used to, acute angle closure glaucoma or acute congestive glaucoma, because congestion is not the main mechanism, and because not all cases develop glaucoma. If you catch them early on, they're not glaucomatous. So you don't have to have glaucomatous optic neuropathy. So we call it a crisis or acute angle closure attack. So what is the management? The management is more or less controversial at every stage of these classifications. There used to be a study in primary angle closure suspect patients, because we have to follow them up for years. So it's very difficult to know the natural history and how they're going to behave over decades. So whether to do as prophylactic PI for these patients from the start to reverse the whole process and flatten the iris, or to just keep them and observe them, because there is a risk that the pressure will rise gradually and cause glaucoma, and there's a risk also of acute angle closure crisis. So do we need to do PI or not? So in one study, very few studies they were, that looked at the natural history of these cases, and they found that around 25% developed peripheral anterior synechiae or high IOP over 5 years. That's around 25% over 5 years. And then two much stronger landmark studies showed up in the last 4 years. One was called the ZAP trial, that was in China, and ZAP stands for Zhongshu, the city where it was performed, and angle closure prevention trial. So this was a very strong study in the sense of it included a very large number of cases who were occludable or primary angle closure suspects, 889 patients. For each patient, they did a PI for one eye and followed up the other eye. The other strength in this study was when they followed up for 6 years, which is a very long time. 75% of the patients continued to the 6 years. And they looked at some outcomes. That these patients who did a PI versus didn't have developed an IP over 24 at any one point, developed PAS 1 clock out, or developed an acute attack, did that reduce the risk when we did the PI? And that they found that the PI halved the risk of developing any of these outcomes. So the risk of developing any of the 3 outcomes was 4% if we continue to observe, versus 2% if we did the PI. But the actual recommendation of the study, believe it or not, was actually not to do PI. Why is that? Because eventually the risk was very low. It really halved it to do the PI, but the risk in general was much, much lower than we thought. It was much lower than the study from India that said it was 25%. It was actually 1% every year. So it doesn't justify to save the 1% to do laser PI for the other 99% every year, just to save this 1% that was going to, and wasn't just the endpoint, mind you, wasn't just to go into an acute attack or something serious. Most of the endpoints were actually developing some peripheral anterior synechiae. Okay? Another study, sister trial from Singapore, showed exactly the same outcome, almost. They also recruited, that was published in last year. It's called ANALIS. It's one of the major landmark studies as well. It recruited a slightly fewer number of patients. Also, each eye was randomized to do a PI or follow-up. And they also found very similar outcomes. They also found that the PI halved the risk of going into one of these outcomes from 10 to 5%. But the risk itself was very, very low. Very few patients developed angle closure attacks. And so the current recommendation is to do PI is only in what is called PACO plus, PAX plus disease. What is PAX plus disease? We don't do PI for all patients, or at least in light of the current recommendations. We only say the PI for patients who are at higher risk than the others. So, for example, these are the NICE guidelines, the UK guidelines for angle closure. Patients with only a good eye, you don't want to risk this eye with an acute attack or glaucoma. Patients, adults, all elderly patients that cannot reach medical care, they develop an attack. Very high hemoglobin, there is slightly higher risk. Or we assume patients that need constant dilatation, regular dilatation for the pupils, they may get into an attack, so diabetics and so on. Patients who are using any antidepressants or anticholinergic cold medications, and they need to go back to antihistaminics that can dilate the pupil, or any medications that can cause congestion in the ciliary body. All these patients should we recommend PI for. If you don't do this, then you need to continue to follow up these patients for life, for IPA, development of synovial angle closure, or progressive zipping up of the ankle, and you need to warn them of the symptoms. So these are primary angle closure suspects. We don't do PI now, but we do it for select cases that are the PAX plus disease. Now, how about primary angle closure? Primary angle closure, like we said, the pressure starts to rise because of the friction and the synechiae and the narrowing. And if we do PI, so PI is a very valid, of course, at this point, you need to do at least a PI for a patient that with pressure started to rise, so we're getting into the way towards glaucoma. So even if you do PI, some of these patients continue to have a high pressure. Guess which ones? Of course, the ones that had peripheral synechiae, the ones that had trabecular damage. Remember when we said that with the friction between the peripheral iris and the angle, patients may develop trabecular damage. Even if you open up the angle with phacoemulsification or PI, they will continue to have a sort of open angle glaucoma because the trabeculum is not filtering blood. Of course, if the PI is too small and becomes occluded, they have other non-pupillary block mechanisms that were not recognized. Or if they have accidentally, and this is bound to happen, primary angle closure glaucoma and another cause of high pressure like primary open angle glaucoma, they may inherit both. So they may continue to have a high PI. So what do we do for those patients with a high pressure, no glaucoma and closure, and still with a high pressure after PI? We can just treat them as open angle glaucoma, give them medications. There are much less risk of acute attack of angle closure now, so we can continue to give them medications like any primary open angle glaucoma patient. And follow them up to set the pressure to the target. But ideally, the recommendation is if they have some cataract, is to remove the lens. This has a much better chance of lowering the pressure, reducing fluctuation, and reducing the drops. So patients with primary angle closure, high pressure, that are not responding to PI, are ideally treated with phaco, especially if they have a cataract. Why not do a trabeculectomy? Trabeculectomy has much higher risks, and at the same time, it shallows the anterior chamber, so the periphery becomes even shallower because of the blood. And finally, there's a risk of going into malignant glaucoma in these eyes, so it's not recommended. So, on the other hand, phaco, when you remove the lens, we said the lens is the main cause, it's the reason for the whole thing to happen. So it widens, it completely deepens the anterior chamber when you remove it. This is the patient before and after lens extraction. Okay, I'll just skip this. And there's very strong evidence from many studies all around the world in different populations showing that the pressure drops very nicely. This is a review of literature of very strong evidence-based studies in the American Academy of Ophthalmology. In 495 eyes, the pressure dropped from 20 to 14 over around 2 years. And the medications dropped as well. So you can choose to do phaco for both primary angle closure and actually primary angle closure glaucoma. You can remove the lens. This widens the angle. Of course, if the patient has a cataract, it's a no-brainer. You can push towards the cataract. The question is whether if the patient has a clear lens. Now it becomes controversial. If the patient has a clear lens and their glaucoma test, according to the Eagle Eye study, which is again a landmark study in glaucoma that was published in Lancet Journal around 10 years ago, they included more patients who are more than 50 years old, and be mindful with this age because you may not be able to extrapolate this to younger patients. And they included patients with glaucoma, with angle closure glaucoma, and patients with high pressure more than 30, not 21 or 24, more than 30 with a high pressure and without glaucoma. And they included a large number of cases, and they compared doing a PI to clear lens extraction problems. These are patients who did not have a trace of catching. And there were a lot of outcomes, including quality of life questionnaires, visual acuity, and to cut the long story short, so we don't get delayed, all the outcomes were in favor of doing phaco for a clear lens in a patient with primary angle closure glaucoma, and in patients with primary angle closure or high pressure more than 50 in this age group in particular. The surgery can be challenging sometimes in angle closure, so if you think that the patient is good, this is not a beginner's phaco, there are always phanekia, you need to dilate the pupil, sometimes you need a Meliorine ring or iris hooks. When you go in, you need to make sure that you enter the anterior chamber beyond the pupillary edge, otherwise it will keep coming out. You need a soft gel technique, so you inject methylcellulose first, and then you inject a hero because it deepens the anterior chamber, whereas the viscoadhesive can coat the endothelium because it's compromised. And you create a large rhexis because the lens is often hard. These are elderly patients, and very with a thick axial lens. Once you start removing the lens, you can feel that the anterior chamber deepens on the spot. But mind you, in these patients, the capsule itself is very lax, so it's very easy to aspirate it by mistake into the aspiration port. So you need to be very cautious when you're peeling the last strips of the cortex. So the peripheral tears phanekia are reduced after lens extraction, but not all cases develop normal pressure. And we don't know which cases will respond very nicely. They all respond fairly well to phaco, but some patients end up being completely off medications, and some patients still require full medication. So we need to know, especially primary angle closure glaucoma, which patients can have phaco alone, and which patients we need to combine this with glaucoma surgery. So there were some studies, but they're controversial, to be honest. Some have shown that the more the PAS, the more the response to phaco alone, and some showed the opposite. The less the PAS, the more the response. But there is a general agreement that the higher the lens won't, primary angle closure glaucoma, and what counts to them that they need glaucoma surgery later on. Why not just combine in all patients from the start? Because we don't want these risks. We don't want all these risks. In two, again, very important studies from Hong Kong that compared phaco versus doing phacotrabeculectomy. In this study, they found that 4 out of 27 patients that had phaco were the ones that required trabeculectomy within the 2-year period of the study. So 23 were salvaged from doing the trabeculectomy with the graft. And in the other sister trial, it was only 1 out of 35 patients that had phaco that required trabeculectomy. So it's very likely that the patient will get away from having a trabeculectomy later. Now, finally, something that would have the benefits of both is the opportunity to combine phaco instead of trabeculectomy, to combine it with angle surgery. Because really, although the risk of requiring another glaucoma surgery is small after phacoemulsification, but the patients usually they need to go back to medications. Around, let's say, half of them need to be on medications. So if the glaucoma is advanced, if these patients are elderly or non-compliant, it's very difficult to keep them stable. And the other thing is because patients may be lost to follow-up. You did the phaco, they're happy, the vision improved, they think everything resolved, and so they disappear, they're lost to follow-up. So you may want to combine this with something to keep them under observation. And the risk of going back and taking local anesthesia several times in a patient with a compromised. اللي حلنا المشكلة دي lately, what's solving the problem now is combining phaco with lens. Lately, there have been many studies in literature that have shown very good results, even with simply doing goniotomy, just putting the gonio lens, doing goniotomy.